Welcome to everybody. I am Paolo Pelosi and head of Anesthesia and Critical Care Unit at San Martino Policlinico Hospital in Genoa. Today we will talk a bit about protective ventilation, which should be used not only in ARDS. No conflict of interest for this specific lecture. And most of the data presented are the results of the effort of a big team, the Protective Ventilation Network, that performed multi-center observational study, randomized control trials, meta-analysis, translational and educational studies all over the world. The concept today is that we need to prevent acute respiratory distress syndrome and how to prevent by using optimized protective mechanical ventilation. What about non-ARDS patients in the ICU? In this large observational study, we found that most of patients are coming after surgery in the postoperative period when depressed consciousness with respiratory failure or cardiac arrest. And mortality in patients without ARDS is quite high in the ICU, almost 17 to 20%, hospital stay and hospital mortality about 20%. And patients at risk of ARDS, without ARDS, they can have mortality up to 30% as compared to patients not at risk of ARDS, around 15 to 20%. Several risk scores have been developed to predict patients at risk of ARDS, like the LIPS score, and we found that LIPS score higher than 4 quite well predicted the hospital mortality and survival in ICU. We also found that in all ARDS patients, overall pulmonary complications were around 27%, and there were 35% of pulmonary complications in patients at risk versus 23% of pulmonary complications in patients not at risk of ARDS. Different mechanisms have been proposed for ventilator-induced lung injury, and we will discuss each of them and how to set in patients without ARDS to avoid and minimize VLI, and also a mention of the possible role of mechanical power. First of all, what about tidal volume? In the original studies, we found that lower tidal volume, lower than 6 milliliters per kilogram predicted body weight, was associated with less risk to develop a pulmonary complication in non-ARDS patients undergoing controlled mechanical ventilation and reduce the risk of ICU mortality. When we look at the epidemiological distribution of tidal volume in patients without ARDS, in more than 1,000 patients, we found that almost 40% of the patients have a tidal volume higher than 8 milliliters per kilogram, and 20% higher than 10 milliliters per kilogram predicted body weight. We launched a few years ago a large randomized control trial looking at the low or intermediate tidal volume, 4 to 6 milliliters per kilogram predicted body weight versus 8 to 10 milliliters per kilogram predicted body weight on major clinical outcomes in patients without ARDS. And the primary outcome was ventilator-free days. What we found, that there was no difference in primary versus secondary endpoints, with a difference between 6 to 9 milliliters per kilogram predicted body weight. In the group treated with lower tidal volume, driving pressure was lower, 11 versus 13 centimeters of water. Peak inspiratory pressure was lower, 18 versus 21 centimeters of water. But the number of ventilator-free days or mechanical ventilation-free days, ventilation days were similar, and all other endpoints were not different. When we look at the subgroups, we found that low tidal volume was associated with higher frequency in hypercapnia and longer mechanical ventilation day when patients were intubated in the ICU, with a higher frequency of delirium, 43 versus 36%. And there were not even difference in the group without ARDS or defoxygenation with a PO2-FiO2 ratio below 200. So our study showed that in non-ARDS patients, we should keep a lower tidal volume between 4 to 6 milliliters per kilogram predicted body weight, if tolerated, with less sedation and assisted breathing. If not, we can allow higher tidal volume, 8 to 10 milliliters per kilogram predicted body weight, and maintain assisted breathing with less sedation. So the first indication is to maintain a tidal volume between 6 to 10 milliliters per kilogram predicted body weight. What about PEEP? Several studies showed that lower 2 versus higher 9-10 centimeter water in non-RDS patients was not associated with major changes on duration of mechanical ventilation or other important clinical outcome. We found that PEEP higher than 5 centimeter water was used in more than 60 to 40% of patients with an FiO2 between around 50% in more than 40 to 70%, and PO2-FiO2 ratio was around 261. We are just finished and completed the RELAX trial, a large randomized control trial comparing low versus high PEEP in patients without RDS. And this study should clearly show if higher PEEP should be beneficial or not in this kind of patients. At the moment, we suggest to use a PEEP not higher than 5 centimeter water in patients without RDS. So PEEP 5 in patients without RDS when needed control mechanical ventilation. What about plateau pressure? We found that patients at risk with RDS, when plateau pressure was higher than 18, the hospital mortality was increased as compared to those patients with a plateau pressure below 18 centimeter water, when there is no effect in patients not at risk of RDS. When we look at our observational data, we found that almost 30 to 40% of patients have a plateau pressure higher than 18 centimeter water during mechanical ventilation. So we suggest a plateau pressure below 18 to 20 centimeter of water in patients during controlled mechanical ventilation and non-RDS. What about driving pressure? We found a straight correlation between the level of driving pressure and the risk of hospital death. As you can see here, higher probability to die if driving pressure was around 15 centimeter of water, while much lower when driving pressure was lower. And in fact, when we look at our observational data, we found that average driving pressure was around 10, with a range between 6 to 13 centimeter water, and driving pressure higher than 13 centimeter water was used in more than 20% of patients. So we suggest a driving pressure below 13 centimeter water, and lowest is better. What about mechanical power? Mechanical power is given by a constant Z098 times tidal volume in liter, times P peaked in centimeter of water minus half of the driving pressure in centimeter of water times respiratory rate. We analyzed more than 8,000 patients without RDS, and we found that when mechanical power was higher than 17 joules per minute, this was associated with an increased risk of in-hospital mortality. Interestingly, we found that the parameters associated with mortality were higher tidal volume and driving pressure, and even higher mechanical power, even at low tidal volume and low driving pressure, was associated with increased risk of mortality. Higher respiratory rate was a very important determinant for mechanical power and the risk of in-hospital mortality. Mechanical power, independently from RDS development or NMBAs, was associated with increased risk of in-hospital mortality. So we concluded that we observed an increased risk of death with mechanical power higher than 17 or 20 joules per minute in non-RDS patients. So we suggest to target mechanical power below 17, maximum 20 joules per minute with a minimal respiratory rate, and to keep pH higher than 7.25. So we conclude in general in non-RDS that we should keep the lung relatively closed and keep them resting to minimize ventilator-induced lung injury. Just gently ventilate the aerated lung, keeping atelectasis at rest, and to target a minimal PEEP for a minimal saturation, 88 to 92%, with a PO2 between 55 to 80 millimeters of mercury. And this might minimize right ventricular impairment. So to conclude, we have to identify non-RDS patients at risk of RDS by LIP score. Mortality is higher in patients with risk of RDS. Protecting mechanical ventilation should be, in general, considered less is more. Thus, tidal volume between 6 to 8 milliliters per kilogram predicted body weight, up to 10 milliliters per kilogram predicted body weight, according to the sedation level. Less sedation and higher tidal volume, up to 10 milliliters per kilogram predicted body weight if needed. PEEP around 5 centimeters water, not higher, with no recruitment maneuver. Plateau pressure below 18 centimeters of water and peak pressure below 20 centimeters of water. Driving pressure as much as possible below 13 centimeters of water. Rescue rate as low as possible, maintaining a pH higher than 7.25. Mechanical power likely to be maintained below 17 or maximum 20 joule per minute, and randomized controlled trials are finished or ongoing to get better knowledge on how to optimize mechanical ventilation in non-RDS patients. Thank you.